President of Indian Orthopaedic Rheumatology Association, who will be talking on small molecules in orthopedic rheumatology, a game changer. I welcome Dr. Jha, Dr. Chandrashekhara from Bangalore, and Dr. S. Amarnath from Bangalore, who are experts for today's One Person, One Talks series to first talk. To introduce our today's speaker, Dr. S S Jha. Myself and Dr. Jha share a same name, Shivashankar Jha is. So he is at present expert in the IOA subcommittee of orthopedic rheumatology. He is patron-in-chief and founder, past president of Indian Orthopaedic Rheumatology Association. He is patron of Geriatric Orthopedic Society of India, past president of Indian Foot and Ankle Society, vice secretary general of Asia Pacific Society for Foot and Ankle for 8 years from 2011 to 2019. He is the past editor of Journal of Indian Foot and Ankle Society. Welcome, Dr. Jha.
Thank you very much. So,
No,
will there be
other speakers also, other panelists? We have Dr. S. Chandrashekhara, a physician, rheumatologist from Bangalore. He is the medical director of Chandre Rheumatology and Immunological Center, Research Center in Bangalore. He has many affiliations, like is the president-elect of Indian Rheumatology Association for the year 22-23. He is the immediate past president of Indian Rheumatology Association of Karnataka chapter, Secretary General of Society of Inflammation Research, and from 2016 onwards, he is the managing trustee of the Immunology and Arthritis Research and Education Trust. He is the executive director of Chandres Journals, which his institution brings every now and then. He is the faculty and program director for post-MD fellowship in immunology and rheumatology at Chandre Rheumatology and Immunology Center and Research at Bangalore. He has many awards to his credits, but the important ones are Sir C.V. Raman State Award for the Young Scientist given by Government of Karnataka in the year 2015. He has been awarded the Oration Award of the Indian Rheumatology Association in 2013, and also Dr. Malaka Reddy Award, Oration Award by the Association of Physicians of India in the year 2000. He has over 100 publications to his credit. Welcome, Dr. Chandrashekhara. We have another expert, an orthopedic surgeon from Bangalore, Dr. S S Amarnath. He is attached to many hospitals like Trustwell Hospital, Mallige Hospital, and various other hospitals. He is also attached with LB Diagnostic Private Limited at Queen Circle in Bangalore. He has done his MBBS and D-Ortho from Mysore University, then Diploma in Trauma from the University of Austria, Vienna in Austria. Then he has done Trauma Fellowship from University of Vienna in Austria. He has worked in United Kingdom in various capacities as Senior House Officer, Specialist Registrar, Senior Registrar, Specialist Junior Consultant, etc. And from 1990 onwards till 2007, he was visiting trauma and orthopedic specialist and junior consultant at United Kingdom. His area of interests are trauma, sport injuries, joint replacements, osteoporosis, medico-legal work, etc. He is an independent orthopedic advisor for Oriental Insurance Company. He is a panel doctor for Star Health Insurance, and he is an invited speaker for many conferences, both by the MNCs as well as our own medical conferences. Yes. He has various membership like Bengaluru Orthopaedic Society, Karnataka Orthopaedic Association, Indian Orthopaedic Association, Indian Orthopedic Society, Indian Rheumatology Association, Bone and Joint Decade Association, Indian Society for Bone and Mineral Research, Indian Orthopaedic Rheumatology Association, Fragility Fracture Network of India, He is the Director of Geriatric Orthopaedic Society Association of India and Secretary of Geriatric Orthopaedic Society of India. He is also Director of ATOMS, that is the Academy of Advanced Trauma and Master Surgeons, which conducts every year conference in Bangalore. Welcome, Dr. Amarnath. Friends, I am the moderator for today's one person, one speaker, one talk. And you can ask any questions and you can send me WhatsApp message on my mobile. I have the technical support from OrthoTV team by Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and Dr. Shamsul Huda. Friends, this talk is live both on OrthoTV as well as IOTV at present. Without much ado, I welcome all the people who are watching this live, as well as the speaker and the expert and the technical support team for the today's one person, one talk series. And over to you, Dr. Jha.
Thank you. Thank you very much.
73B.
I'm not getting my...
That scroll bar, you can just move it. That share screen scroll bar, you can keep it down. Yeah.
Yes. Yeah. Thank you. Thank you very much, Dr. Shivashankar. At the outset, I must say that I feel so very happy and obliged that you awarded this one person, one talk to me in your second series. And I'm similarly more happy and excited to be having as expert Dr. Chandrashekhara, a famous rheumatologist of the country, who has been associated during the trial of small molecule as well. And Dr. S S Amarnath has always been a very good companion in the journey to orthopedic rheumatology. Well, my initial thanks also to all the team members, including Dr. Ashok, Shyam, who instantly could manage this talk. Well, friends, let me take you through the journey that management of RA has been through. But in spite of this long journey along the more than 40 years, the management is still evolving. And it has started from use of analgesics and NSAID to conventional DMARDs to biologics, and in between the B-cell therapy, and similarly it was very quickly followed with biosimilars, and also the microimmunotherapy, which really is used for management of intractable cancer, but microimmunotherapy can also help patients of rheumatoid arthritis. So JAK inhibitors have been the latest in this series, but what next is going to evolve? Let me take you back to 1980, when methotrexate was launched, which continues to be still be the cornerstone, and in 1/3 of the patients, methotrexate alone controls the disease. In 1990s, revolutionary narrow targeting cytokines compared to the general immunosuppression were introduced, and TNF alpha inhibitor targeting a single cytokine worked within the extracellular space. I will repeat, it worked within extracellular space because the JAK inhibitors, they work within the intracellular space. So they were targeting the TNF-alpha inhibitor within the extracellular space, were targeting cell surface receptors. Well, in the past, not only 1 decade, during the last 2 decades, there were revolutionary TNF inhibitors introduced. They were infliximab, etanercept, adalimumab, golimumab, and certolizumab. Apart from that, as I have told you, anti-CD20, the monoclonal antibody rituximab was also introduced, and IL-1 receptor inhibitor, IL-6 receptor inhibitor, particularly the tocilizumab, was so much in demand during COVID days. IL-17 receptor inhibitor, secukinumab, and IL-23 receptor inhibitors were also introduced. And the last in this series is JAK inhibitors. Well, in spite of all these achievements, there have been challenges in the management of rheumatic diseases. So despite dramatic improvement, there have been unmet needs. What are those unmet needs? Some of the patients are refractory to treatment, or you can say the disease is refractory to treatment. Patients are losing efficacy. Patients are not tolerating the biologics. Friends, I just wanted to tell you, especially our orthopedic colleagues, that whenever we treat a patient of rheumatology, the target or the goal of therapy is remission, and not only remission, but sustained remission. So there has been a paradigm shift from controlling symptoms to controlling the disease process with abrogation of inflammation. Well, remission is defined as complete absence of clinical signs and symptoms of synovitis, and there is no swelling over the joints. Elimination of silent synovial inflammation, normalization of markers of systemic inflammation such as ESR, CRP, and there is little or no radiological progression. Well, low disease activity is an acceptable alternative, especially when remission is not possible in established long-standing disease or when comorbidities or other patient factors limit DMARD option. Well, in axial spondyloarthropathy remission, there has not been a consensus on the definition of remission, but validated definition of low disease activity like S Jha is one tool. If it should be less than 1.3 in active disease, or it serves as a target for therapeutic strategy, and reduction by at least 1.1 during treatment is also very significant. Well, talking about cells involved in rheumatoid arthritis pathology, so under the influence of genetic and environmental triggers, the dendritic cells, the secondary lymphoid tissue, the bone marrow, stroma, fibroblast, osteoclast, they all get engaged and there is joint damage. And so numerous cytokines involved in both innate and adaptive immunity are implicated in the pathogenesis of rheumatic diseases. The innate immune system consists of all the cells of the WBC series except lymphocytes. So monocytes are there, neutrophils are there, eosinophils are there, and apart from them, the macrophages or dendritic cells, natural killer cells, innate lymphoid cells, and mast cells are there. They are first line of defense necessary to activate and instruct the adaptive immune system, which basically consists of lymphocytes, T cells, B cells, and natural killer T cells. The autoimmunity, which is the hallmark of such diseases, there is loss of tolerance to self-antigens. Now, friends, there are a variety of receptor superfamilies that mediate cytokine signals and are thought to play a role in the development of rheumatoid arthritis. So the examples include JAK pathway, and JAK pathway is one which we are going to talk about it in detail. The MAPK pathway, which is mitogen activated protein kinase pathway. The third one is signal transducer and activator of transcription, STAT pathway, nuclear factor kappa B pathway, and PDE4 pathways. Out of all these pathways, we are going to talk about the JAK and the STAT pathways. This I have already said. So friends, coming to what is the topic of this evening, the first oral small molecule inhibitor that belongs to a novel class of drug called JAK inhibitor. Novel is important that it was never similarly developed earlier, and this is a small molecule. So this is tofacitinib. Now, tofacitinib is a JAK inhibitor, and the Janus is the name which comes from Roman god Janus. And this is a two-faced god, as you can see in this photograph. So this Janus looks at the past and also at the future, and hence has been so named. Well, this JAK kinases are two-faced with respect to their two domains. JH1 is catalytic domain at the carboxyl end, and JH2 is a kinase-like domain lacking in catalytic activity but having important regulatory role. So one is catalytic and the other is non-catalytic. So JAKs are receptor tyrosine kinase family in mammals, and they are in count only 4, 1, 2, 3, and type 2. Well, JAK are attractive targets for autoimmune disease treatment. They mediate signaling via surface receptors for several pro-inflammatory cytokines involved in rheumatoid arthritis. So friends, tofacitinib, the oral drug, which is revolutionary because all the biologics till now, they were and they still are, they have to be either given intravenously or subcutaneously. So this new small molecule was the first JAK inhibitor, and US FDA approved in November 2012, but Europe, it was only in March 2017 that it was approved. Now, other than RA, there was US FDA approval for psoriatic arthritis, ulcerative colitis in 2018, 2020 juvenile arthritis, and the best part was that though its use had started in ankylosing spondylitis, but the final approval came in December 2021. So all the cases of spondyloarthropathy can get treated with tofacitinib. Now, very briefly, let's talk about JAK-STAT pathway. So the STAT pathway was the first one which was discovered in 1988, where the protein binds to interferons, and it was in 1992 that JAK was developed in 3 separate labs almost at the same time, and a word was coined, JAK-STAT pathway. Now, what this JAK-STAT pathway's limitations are? As I told you, the JAKs are only 4. So each of the 4 JAKs is used to get associated with multiple different receptors. Similarly, stats are only 7, and that is their limitation. So many inflammatory cytokines and other signaling molecules rely on JAK-STAT signaling system. I must tell you at this point itself that all these JAK-STAT pathways are responsible for maintaining the immune system, the hematopoietic system, the endothelial cell integrity, and homeostasis. Mechanism of action is very clear. I said tofacitinib acts within the cell. Now see what happens. A set of cytokines like IL-2, 4, 7, 9, 15, 21, and even others, they are docking with the receptor gamma chain on the surface of the cell membrane in the extracellular space. So this activates the JAKs which were lying inactivated stage. This releases the phosphate and it activates further or docks with inactive stats which gets activated, and then this gets transcripted into the nucleus where pro-inflammatory cytokines like TNF-alpha and interleukin-6 are produced. So this series of action gets a break when tofacitinib is there, because tofacitinib is a JAK-STAT inhibitor. So cytokine, as you have seen previously, normally binds to its cell surface receptor, leads to receptor polymerization or dimerization. Next, when tofacitinib is present intracellularly, it inhibits the phosphorylation and activation of JAK2. So now JAK cannot phosphorylate the cytokine receptor, and so the receptors cannot dock with the stats. Now, since the stats cannot dock, they are not phosphorylated or activated, and hence gene transcription of cytokine production are thereby inhibited. So we do not have TNF-alpha, IL-6, etc. Well, friends, they are direct inhibition and indirect inhibition, and this is just to tell you that the IL-17 and IL-23, these are two which have become very important. So there is direct inhibition of IL-23 along with IFNG, IL-7, etc. And there is indirect inhibition of TNF-alpha, IL-1 and IL-17. All these three which gets indirectly inhibited are so very important. Now, the same photograph which I have already discussed. So targeted synthetic DMARD tofacitinib has all the benefits of a small molecule, that it increases biologic disease activity across multiple pathways. It inhibits intracellular, again mind you, it is intracellular signaling of cytokines and growth factors. Chemically, it is more related to traditional methotrexate than to biological DMARD, but acts like biological DMARD in their suppression of cytokines. Onset of response occurs within 2 weeks and efficacy gets maintained even up to 5 years. Well, pharmacokinetics, we will keep on repeatedly discussing this, that absorption is rapid, 74% gets absorbed. Cmax is reduced by 32% when administered with high-fat meal. But this again is controversial. Distribution, protein binding is 14%, and this is predominantly with albumin. So if a patient has hypoalbumin, then this will be available in the circulation. Well, metabolism, hepatic is 70%, and it is eliminated in the urine through the kidney as unchanged drug. Well, this CYP enzymes are so very important, which inactivate the metabolites. Well, dose, this is very important for a clinician. Adult patient, ideal dose is 5 milligram twice daily. But here itself, I must tell you that for ulcerative colitis, it is 10 milligram BD. Hemoglobin, if it is less than 8 gram, or there has been a decrease of more than 2 gram, then interrupt the dose till the hemoglobin normalizes. Now, moderate or severe renal impairment and moderate hepatic impairment, reduce the dose to 5 milligram once daily. Lymphocyte count less than 500 cells and absolute neutrophil count less than 500 cells. In both these situations, discontinue the dose. But as far as absolute neutrophil count is concerned, when it goes below 1000, interrupt the dosing, and when 1000 gets resumed, more than 1000, resume 5 milligram twice daily. Well, whenever ketoconazole and fluconazole, representing the CYP3A4 and CYP2C19, they have to be used. Use it in 5 milligram twice daily dose. Well, for pediatric use, the weight, if it is less than 40 kilogram, 5 milligram OD, more than 40 kilogram, it is 5 milligram BD. Age above 60 years, 5 milligram OD only should be given, for reasons also that I will be discussing later. Now, serious and localized infection should not be used. At increased risk of gastrointestinal perforation, never use it. Monitoring has to be lymphocyte, neutrophil, hemoglobin tests should be performed at baseline and approximately 4 to 8 weeks after initiation, with treatment and every 3 months thereafter. Lipid profile, liver function, renal function have to be monitored, and pulse rate and blood pressure also must be periodically examined. Well, friends, to make the talk shorter, I would skip over the guidelines, and I would only like to highlight that this is, though there are reports that it can be used solo. But this is a drug which is recommended as second, third, or fourth drug in the management of all these diseases. Well, you can see that Applar 2015 also said that tofacitinib may be considered if the biological DMARD has failed. Euler 2016 says that if the treatment target is not achieved with the first CS-DMARD strategy, when poor prognostic factors are present, addition of a biological DMARD or targeted synthetic DMARD should be considered. So similarly, 2016 also, when poor prognostic factors are present, addition of a biological DMARD or TS-DMARD must be considered. Now, as you can see here, tofacitinib is recommended for the use of psoriatic arthritis. There are details which I would like to skip over. Well, now, as far as it's used in a special situation are concerned, pediatric use, the safety and effectiveness is not fairly established, but I have mentioned about the weight, and roughly 12 to 14 years should be the age after which it should be used. Geriatric use, I said, there is higher incidence of infection in elderly in general, so caution should be used. when treating the elderly. Well, diabetes, higher incidence of infection in diabetes population in general, caution should be used. Pregnancy, contraindicated. Lactation, contraindicated. And here itself, I would like to highlight that even for a lady who wants to become pregnant, minimum 2 to 3 months earlier, the drug must be stopped. Well, renal impairment and hepatic impairment, they have to be investigated, but mild impairment, 5 milligram twice daily, I have already told you. Severe renal impairment, even 5 milligram once daily can be given. But hepatic impairment, mild 5 milligram twice daily, moderate impairment 5 milligram once daily, but severe hepatic impairment, do not use it. Well, contraindication should not be administered who are hypersensitive to this drug or any of its components. The other ones I have already told you. The common adverse drug reactions are infection and infestations like pneumonia, influenza. Herpes zoster is a big bug bear. So herpes zoster has been has appeared in many of the patients. UTI, sinusitis, bronchitis, nasopharyngitis, pharyngitis, etc. Anemia, headache, hypertension, gastrointestinal disorders like abdominal pain, vomiting, diarrhea, nausea, gastritis, etc. are there. Well, drug-drug interaction, we have already discussed about it, that dose adjustment is required when you use it with either ketoconazole or fluconazole. But if you are treating a patient of tuberculosis and the patient has been on rifampicin, co-administration is not recommended. Well, immunosuppressive drugs like azathioprine, tacrolimus, cyclosporin, again co-administration is not recommended. Well, so tofacitinib as an intracellular Janus kinase inhibitor inhibits inflammatory process and affects the expression of pro-inflammatory cytokines. It can be administered orally, which is the preferred route of administration. The drug can be even crushed and administered with water, which is important for individuals with dysphagia. Here itself, I would like to say, I'm going to say it again, that the latest drug, upadacitinib, is one which should not be crushed. That one tablet has to be taken as a whole. Now, another important aspect is this short half-life, which plays a role in the event of elective surgical procedures. And American College of Rheumatology recommends interruption of tofacitinib therapy 7 days before an elective major surgery, which is significantly less than the case of TNF-alpha inhibitors. So, immunogenicity, which may affect treatment outcomes, is not expected in the case of tofacitinib due to its chemical structure. Normally, what we say that we must add methotrexate to any biological because drug resistance do not develop or autoimmunity does not develop too strong. So, but as far as immunogenicity is concerned, tofacitinib can be used alone, but can also be used with methotrexate. TNF-alpha inhibitors are contraindicated in individuals with class 3 or 4 heart failure, while tofacitinib is not. So this is very important. And here itself, I will like to say that a patient with coronary artery disease, their TNF-alpha inhibitors are to be preferred over tofacitinib. Well, tofacitinib can be used in individuals with several severe renal impairment, also in those undergoing dialysis, although eGFR is less than 30 ml. This necessitates only a dose reduction to 5 milligram daily. So I have overemphasized on the renal part. The drug may be safely used in individuals with mild hepatic impairment, and tofacitinib has a beneficial effect on pain, and an analysis of data from clinical trial shows that a significant alleviation of pain is achieved as soon as after 2 weeks and is maintained over time. Well, coming to the other one, very briefly, baricitinib was there as the new JAK6 inhibitor. Baricitinib was approved. Look at the years that European countries, they almost in the same year approved tofacitinib and baricitinib. Whereas here, the US FDA delayed it and it approved it in 2018, a year later. So this was the second JAK inhibitor. This is a reversible inhibitor for JAK1 and 2. Tofacitinib was JAK1 and 3. Now the oral dose is 4 milligram or even 2 milligram once daily. So that was an advantage, that once daily dose can be given in this one. Now tofacitinib is available in the market in sustained release form of 11 milligram. The monotherapy or in combination with methotrexate. So whatever JAK inhibitors have been there, they have been got the approval that they could be either monotherapy or preferably in combination with methotrexate for treatment of moderate to severe active rheumatoid arthritis or spondyloarthropathy in adults who have responded inadequately to or who are intolerant to one or more DMARDs. I was just generalizing the use of any JAK inhibitor, but as far as this baricitinib is concerned, it is only and only for rheumatoid arthritis and not for spondyloarthropathy. And I must tell you that the results are very gratifying. During the COVID time, there was a relaxation to use this drug, and it was available other than the originator company, and we had the opportunity to use the cheaper ones in very many cases of rheumatoid arthritis with very good relief. Now the latest drug is upadacitinib, not yet available in India, but is internationally available, and this is a only JAK1 selective inhibitor, no 2, no 3, and it is being investigated for rheumatoid, Crohn's, ulcerative colitis, atopic dermatitis, psoriatic, and axial spondyloarthropathy. So once we have talked about all the three, now we can say that the JAK can be classified into first generation and second generation. First generation is tofacitinib, baricitinib, which we are more familiar with, and the second generation is upadacitinib. So this is specifically, you will look at them, that most of them are JAK1 inhibitor. Now upadacitinib was engineered to be selective against JAK1 over JAK2, 3, and type 2, as I have told you. Rationale for this was that specifically targeting JAK1 should ensure a strong anti-inflammatory effect while minimizing side effects associated with inhibition of JAK2 dependent processes. And those processes were development of red blood cells, platelets, myeloid cells. So this does not have any depressing effect on blood cells, platelets, and myeloid cells. Well, the US FDA indications: adults with moderate to severe active rheumatoid arthritis who have had inadequate response or intolerance to one or more TNF blockers, adults with active psoriatic arthritis who have had an inadequate response or intolerance to one or more TNF blockers. Adults and even pediatric patients 12 years of age and older with refractory, moderate to severe atopic dermatitis whose disease is not adequately controlled with other systemic drug products, including biologics, or when use of these therapies are advisable. This does not concern us. Well, administration, in short, the doses are 15 milligram and 30 milligram as extended release tablets for oral consumption. Before starting, must investigate and assess underlying tuberculosis, either active or latent, and the other assessments like any other JAK inhibitor concerns liver function, viral hepatitis, pregnancy status, etc. And it is not recommended to be used concomitantly with other inhibitors, not that you co-administered it with tofacitinib or baricitinib. Even biological DMARD agents are not to be used simultaneously. Azathioprine and cyclosporin, which are immunosuppressants, should not be co-administered in cases of rheumatoid arthritis especially. Well, dose rheumatoid arthritis, as I have told you, 15 milligram orally as monotherapy. Medication can be taken with or without food. Recommended as a whole 15 milligram tablet without splitting or crushing the tablet once again. Psoriatic, yes, recommended daily dose is 15 milligram as a monotherapy. The medication can be taken with or without food and recommended as a whole 15 milligram tablet. So same. Now, these are some of the studies, and the efficacy and safety of upadacitinib were generally consistent when administered as monotherapy or in combination with non-biological DMARDs through 24 weeks, supporting the use of upadacitinib with or without non-biological DMARD in psoriatic arthritis. Now, this is a 30 milligram dose, but not the 15 milligram dose was superior to adalimumab. So when we compare with adalimumab, the 30 milligram dose is superior. So the percentage of patients with psoriatic arthritis who had an ACR20 response at week 12 was significantly higher with 15 milligram or 30 milligram than with the placebo. Now, friends, I am coming to a subject which is very close to my heart, management of osteoarthritis of the knee. And while talking about small molecule, I thought I will definitely talk about role of small molecules, oral and intra-articular, in the management of osteoarthritis. Well, friends, the first difference in the use of small molecules was that acceptance of inflammatory theory as far as osteoarthritis was concerned was there, has been accepted now. Now, there has been focused management which has targeted the subchondral bone, the chondrocytes, and the inflammatory processes, and mainly evolution of small molecules, that too intra-articular, and they are Loresi, Vivint, and BNTA. So again, the oral therapy of use of tofacitinib, also I say that it is a silver lining in the management of osteoarthritis. Now, coming back to the changing pathogenesis of osteoarthritis, there has been a switchover of inflammatory theory. It was in 1990s that progress in molecular biology showed that discovery of inflammatory theory, many soluble mediators like cytokines or prostaglandins can increase the production of MMPs by chondrocytes. Now, as late as 2017, further imaging studies by Wallace et al. Have demonstrated localized inflammation contributing to osteoarthritis. But this theory was not accepted till 2000, but finally it came to be understood that the inherent synovitis in osteoarthritis is the critical feature and driver of osteoarthritic process. Well, as I have told you, the seat anchor of pathology has been subchondral bone in osteoarthritis, which acts as a mechanical damper and as a source of inflammatory mediators implicated in the osteoarthritic process, in degradation of deep layer of the articular cartilage also. So initially considered that osteoarthritis is cartilage driven, it is much more complex disease, and the inflammatory mediators released by cartilage, bone, and synovium. So the novel non-surgical management is intra-articular use of small molecule inhibitor of WNT signaling pathway, and this loresivivint has gone through phase 3 trial and actual disease modifying osteoarthritis. So we are talking of, as we talk about DMARD in rheumatic diseases, in osteoarthritis we say DMOAD. So disease modifying osteoarthritic drug is this is likely to be the ideal one or the gold standard one. And only 11th November 2022, a month earlier, 1 month and a half, efficacy data from phase 3 trial in osteoarthritis has been released by Samumed company, and it says that yes, it is possible to regenerate cartilage. There is protection from cartilage catabolism, and there is significant difference in joint space width. Now, joint space width, if there is a significant difference, this is the ideal DMOAD. Friends, the intra-articular small molecule BNTA also is effective, and it has been shown that it promotes cartilage extracellular matrix generation, thereby inhibiting osteoarthritis development. Well, when I say there is silver lining in management of osteoarthritis, because tofacitinib has opened up a new vista in management of osteoarthritis. So not only tofacitinib, I keep sulfasalazine also in the same track, because they effect on the protein profile of articular cartilage. Novelty of tofacitinib in osteoarthritis is that it increases cellular levels of adenosine, which is known to have anti-inflammatory activity. Friends, now the moot question is that is tofacitinib or the small molecule, any one of them, is going to replace biologic or is going to supplement biologic? To understand this, we must try to differentiate between the two. The biological DMARD have a systemic route, whereas the targeted synthetic have oral route. The biologic ones are narrow targeting cytokines, whereas the small molecules targets increasing biological disease activity across multiple pathways. The biologics TNF-alpha inhibitor targets a single cytokine, whereas TS-DMARD targets multiple cytokines. The TNF-alpha works within the extracellular space, targeting only the cell surface receptors, whereas TS-DMARD inhibits intracellular signaling of cytokines and growth factors. I have already told you that TS-DMARDs are chemically more related to traditional methotrexate than to biological DMARD, but in action, they are more like biological DMARD in their suppression of cytokines. onset of response occurs within 2 weeks, and efficacy maintained up to 5 years. Well, I was talking about herpes zoster. So whenever we are using targeted synthetic small molecule, so before initiating and even during therapy, we can use for biological DMARD, targeted synthetic DMARD, and even for conventional synthetic DMARD, we can use pneumococcal influenza before initiating therapy, and also while already in therapy. There is only one exception, that prophylactic immunization with live zoster vaccine must not be done while on biological DMARDs and also TSDMARDs. So, friends, in summary, I would like to highlight that there is a changing treatment paradigm with the arrival of JAK inhibitors. This is a second-line therapy after methotrexate in DMARD naive patients, likely to become first-line agents because more effective than methotrexate. Long-term safety due to monitoring and vaccination can be ascertained, and there has to be a unique mechanism of intracellular action, rapid onset of clinical response and efficacy. So the effects look very promising. Thanks. Thank you very much. I will stop sharing.
Yes, please stop sharing, sir. That was wonderful exposure, and you have covered in a short time almost all the aspect of the JAK inhibitors, and you have given a silver lining about its potential use in osteoarthritis. That's a good thing. Dr. Amarnath and Dr. Chandrashekhara, you can unmute yourself and you can ask few questions. I have got a question which has been sent by Dr. Suman Sinha from Delhi. He asks, for us, we are clinicians, we are guided by the efficacy and safety of a drug and not by the size of its molecule. So, sir, what is the significance of leveling it as a small molecule drug? So, there's a basic question, why it is called as a small molecule drug?
Yes, a very good question. That small molecule has only been advocated because of its size. And because of its size, it is intracellular in its action, number one. And since it is intracellular, it is able to inhibit the JAK-STAT pathway. So size does not matter, but size is important. And the size is almost to the extent of 700 to 800, less than 900 adapters. So it's a very, very small size. But recommendation is not because of size, recommendation is because of the mechanism of action that is there.
Yes. Yes, Chandrasekhar, any question from you?
Yeah, I mean, before the question, I think I'll just add some few comments, actually.
Right.
I think there are a few, I think I should congratulate Dr. Jha for a very nice and a very elaborative lectures. I mean, just add a few things from how, as a rheumatologist plus an immunologist, we look at these molecules. I think we call this as a small molecule basically because it was considered as one of the biologics. We wanted to give a designate as a biologics because these were target specific, unlike the methotrexate and other drugs. That's where they want to distinguish between the biologics of a proteinaceous molecules, what we used to want to call it as biologic DMARDs, and others as the target specific DMARDs, or other alternative name we wanted to use it as a small molecule DMARDs of a biologics nature. I mean, that's how the term went on, and we started using it as a small molecule, big molecules, and those on. And why are we having so many drugs that are required? And is one drug going to replace another drug when it comes to the therapeutics in autoimmune disease, including rheumatoid arthritis? Answer to that question as an immunologist and rheumatologist is no. It is not right for us to think that the small molecule is going to replace the biologic DMRs, or biologic DMR is going to replace methotrexate, or methotrexate is going to replace the leflunomide. The reason is all these autoimmune rheumatic diseases, which we group them together, if we group, they are heterogeneous diseases, because in some we have a TNF drive more, in some we have IL-6 drive more, in some we have overexpression of these targets like JAK proteins, in some NKBH pathways are predominantly expressed. And in addition to that, the immune system has been developed by nature in such a manner to subvert any single block which can occur over a period of time. I mean, that's something which is very interesting for all of us to know, is because it's been developed in a way so that it subverts any block, because this has been developed with an intention, because many of the infectious diseases, infections, organisms, they know to block the immune system. They block one pathway. That's why immune system has developed to shortcut it so that it still fights the infection. In autoimmune diseases, what really happens is, if I block pathway A, it has been learned by its habit to shunt that pathway and still continue to have the action. Though, of course, it's on self-protein or self-structure, habit of an immune system learning is to always circumvent the block. So that's why we are not going to, or not likely to have one tablet or one medication as an answer to the entire spectrum of rheumatoid arthritis. I think with this brief note, I think, what's your take, Professor Jha, on screening for tuberculosis with reference to the tofacitinib?
Ideally speaking, yes, we must screen all the patients for any latent tuberculosis, and that can be done by a simple MAN2 test. And if you are suspicious on MAN2 test that yes, it could be, then we can go for the gold is what we say, gold
gamma interferon
gamma interferon test.
Yes.
And if at all we have to treat the patients, even isoniazid will help us.
Yes, I think you made it clear in one of the slides that don't use tofacitinib with rifampicin. I mean, that's one of the interesting things which all of us has to keep a watch, because rifampicin interferes in the efficacy of tofacitinib and vice versa.
Yes, Dr. Amarnath, any question from you?
I think Chandrasekhara stole my question in a way for the tuberculosis. I had written down, and then no problem. Now, as a general orthopedic surgeon, we have been dealing with a lot of arthritis, and obviously, it is nice to have a rheumatoid, expert in the panel to give us the clarity, and also from the immunology point of view, Chandrasekhara, I think you have made the point very, very clear. I think moving forward, I mean, just a suggestion here more than a question, Shiva. No, I think we need to work hand in hand as a team. It is not an orthopedic surgeon doing this, or orthopedic surgeon doing that, or immunologist, or a rheumatologist dealing with that. So this is where we can come up for a better patient management care, which is happening. In many of the times, I have been in touch with many rheumatologists in Bengaluru, and Chandrashekhara also, and obviously the president of IRA, Dharmanand, and others to take the name. And we have been definitely dealing with that. The question comes to an orthopedic surgeon now, obviously, to the investigation part, 1. 2, when we start the therapy as the DMARD, for a rheumatoid, okay, we are going to talk about this. We can give as a secondary or tertiary line, tofacitinib comes into picture. Now, when we're talking about the seronegative part of it, the arthritis, which is going to be the spondyloarthropathies, like it could be psoriatic, how do we do it? Where DMARDs may not be the first choice, because you may not use methotrexate in, Anki spine, or even in psoriatic. Obviously, we are using it, but how do we deal with it? In DMARD, in rheumatoid arthritis, we are going to give the first line. If it fails, then we can definitely have a combo therapy with methotrexate and TNF alpha blockers, or if the patient is not able to afford, we can go into a lot of logistics we work on. So how do we deal with it? Say, for example, the the number of rheumatologists available in the country are handful compared to 40,000 plus orthopedic surgeons in the country. Being an IRA member for 30 plus years now, I know it's not an easy affair for everyone to be in the segment. So how do we approach and how do we take it forward for a better patient care? My question for Dr. Jha and Chandrasekhar to sort of chip in as well.
Right. I think this is not the platform to discuss about
Okay.
which one is to be treated by a rheumatologist and which one is to be treated by an orthopedic rheumatologist, if we can say so.
Wonderful.
You have rightly overemphasized that it is the number game of the specialist, because orthopedic surgeons are scattered all over the country, every nook and corner. They do not make an initial mistake in making a diagnosis and then treating the patient. And here itself, this orthopedic rheumatology was established to teach them, if I can say so, or train them into making a diagnosis, investigating the patients, and treat the patient to some extent, after which the patients could be referred. Now, I always say that when we examine patients, history becomes so very important. And a case of a rheumatoid arthritis might be coming back to you, sit on your table and say, well, I have got pain here, this hand, this hand. So bilateral, symmetrical, many times we say the patient gives you the diagnosis. But it is really orthopedic surgeon's bread and butter when he keeps on getting patients of back pain. And then you have to see that he is a mechanical backache patient or a spondyloarthritis patient. Now you have to ask some positive questions. Had you ever had pain in or around your heel? Or is there some bowel irregularity that you are having? So positive questioning also will be important. And so I say history is very, very important. So talk to the patient till the patient gives you the diagnosis is true here in rheumatology, especially in spondyloarthropathy as well. Dr. Chandrasekhara.
Yeah, I think you almost covered the entire thing. So the spectra is, as we said, I always keep telling in most of our conference too, is see, it's difficult for both the patient as well as the rheumatologist to reach to everybody. So that being the case, it's always best to train at the best, where the patients can be managed to the best levels. And as you said, it's always best to differentiate the disease which can be handled at the base levels, and the disease like SLE, vasculitis,
Right.
Any of those diseases which needs an extraordinary attentions, and even a small error can cause a huge issues, which needs to be a quick reference to a specialist. Fundamentally, we always say that arthritis plus with a problem which are likely to have some organ damage need a quick reference. A rheumatoid or an ankylosing or a psoriatic, where even if it causes a little damage, which is replaceable, it's not that difficult to replace a joint, unlike replacing a kidney or replacing a lung, which is extraordinarily expensive and also not an easy feasible workout. So those are the fundamentals on which, if the treatment is delivered to the patient, because end game is we need to care his benefit, for which who takes care is not what matters to the patient. What matters to the patient is what did he get and
Right.
what mattered for him to get his best health. I mean, that's the best point with which we need to work. I mean, in the same point, I will address one of the question I think Dr. Shivashankar has posted in the WhatsApp group. I think, shall I take it up, Shivashankar?
He's muted. He's muted.
Yeah, please go ahead. Yes, Chandrasekhar.
Yeah, I mean, this was on the preventive rheumatology. I think somebody has asked a question that suppose if there is a positive family history, and if anti-CCP has turned positive and patient is asymptomatic, is there any method in which we can prevent the development of that individual developing a frank rheumatoid arthritis? Answer to that question is currently we are not really sure what to do with this set of patients. If the patient doesn't have any symptom, it is best not to do any screening test of any of these rheumatic diseases. Don't have either rheumatoid factor, anti-CCP, ANA, any of these tests in an individual who do not have any symptoms and signs. The reason is mere presence of any of these autoantibody doesn't give a guarantee that the individual is likely to develop an autoimmune disease, and the disease development could range anywhere from few months to several years. The rheumatoid may develop after 15, 20 years. And most of the drugs that we have currently to treat, manage, or prevent have more adverse event than letting the disease to develop after 5, 10, 15 years and then treating at that point of time. There are few things which can help in preventing them. These are mainly lifestyle changes. If he is a smoker, ask him to avoid smoking. If he is sedentary, ask him to become more physically active. Change in food habits, we are still not very sure any of them can change it. I mean, there are a few simple studies which says that inflammatory diet, non-inflammatory diet, and those kind of stuff. I mean, we don't have a full science benefit or science advantage. I mean, changing a little food habit, as long as it's not going to impact him from his lifestyle, you can suggest him, and otherwise it's also not a mandatory thing. But smoking, preventive smoking, making him physically active from less sedentary style could postpone the development of rheumatoid arthritis a bit. That's where we are. And there are trials which are going on in large number using methotrexate, using hydroxychloroquine. And there is one small trial even using rituximab was done in few 10, 20 patients, but most of them were not really very encouraging at this point of time currently. So answer to your question is, currently we don't have any preventive steps. Some lifestyle changes can help them out actually.
Can I add one thing? That
Yes.
we can keep them under watch.
Right.
Number one. Number two, when the symptoms appear, we can interfere, and there is an early window of opportunity. And that window of opportunity has to be utilized. And it is in this stage that the disease can even get aborted.
That's true.
Yes. Thank you. Dr.
Yeah.
Jha, I have got a question. For COVID, to prevent the interleukin storm, instead of tocilizumab, can we use tofacitinib?
Oh, yes.
Because
It had not only tofacitinib during the COVID days, even the baricitinib was there. The government relaxed the ban, and the originator company had to budge, and many other companies were there, and the names were all added with a prefix, COVID-nib or something like that, in so many products. But now, after the COVID was over, they fought a case, and it had to be withdrawn. So, talking of tocilizumab, that reminds me one thing. I was looking into Dr. Chandrasekhar, 2022 EULAR recommendations have come. And there I have found that now they say that whenever you are using targeted synthetic DMARDs, it has to be associated with one of the biological DMARDs or one of the CS-DMARDs. And if both biological DMARD and TS-DMARD, they have not been successful, it is tocilizumab which has to be used, or maybe sometimes they have written that even tocilizumab can be combined with targeted synthetic ones. You must have gone through the 2022 recommendations.
No, actually, see, few points I think for practical tips with reference to these recommendations is, these recommendations are based on the date of birth of these molecules.
Right.
Rather than any of the head-to-head comparison that is available. See, if you see that TSDMRs were still kept on the third option or a fourth option after the biologic DMRs, it's basically because of the date of birth, not because there is no head-to-head study like saying that methotrexate failure or a leflunomide failure. Introducing TSDMRs, is it advantageous compared to the biologic DMRs? You don't have any studies which gives that particular data or information. Why I'm saying is this, actually, if you come back to India with the Indian setting, with the available generic target-specific DMR tofacitinib, now many of us have jumped the lanes. We don't now try the biologic DMRs. We just move to use the TSDMRs. Are we legally right, or are we not? Are we right as per the recommendation? Answer to that question is, recommendations is of ACR. Don't worry, we have not. IRA has still not produced any recommendation with reference to that. But from the practical standpoint of view, that you trying out a biologic DMRs and failing with which is going to be terribly expensive with the current scenario compared to the target specific DMRs, that small molecules. So it's at the best interest of the patient and the economy. We jump the lane once the patient fails with methotrexate or any conventional DMRs. The next option we look forward is to go for a target-specific DMRs. Because really speaking, the recommendations, as I said, is not based on the head-to-head comparison. There is no head-to-head comparison available which says that after this, which is the best option to go with.
Well, cost becomes a factor, and with cheaper availability of tofacitinib, the cost factor does not remain a factor, and this has become so important.
Yes.
Yes, Dr. Amarnath, yes.
Yeah, I think partly for my question, both of you answered that in a part. Now, to understand, there's a patient who is on alpha TNF blocker. Now, he or she wants to either stop or probably look at, one, is there a remission and probably exacerbation happening sometimes even with the, are we okay to shift from alpha TNF to JAK? Either one or two or three.
Sir, you want me to take up the question?
Oh, yes, please.
Right. No, see, when the patient is in remission, if you are sure that patient is in remission, the best option is to slowly wean him off from the anti-TNF drug. So say there are two ways to do it. Say patient is on adalimumab, space the adalimumab from fortnightly to monthly once, and monthly ones to the 6 weekly ones, and the patient is not relapsing, discontinue it. Once for all, you can try to wean away from any of these biologic or TSDMRs, maintain him with methotrexate or hydroxychloroquine. That's the current recommendation, which is slowly coming in, creeping in, withdrawing the DMRs.
Yeah.
And switching over is something which we suggest when there is a failure. Failure could be both. Either it could be a financial failure, patient can't afford to continue with the biologic DMRs, shift to the TSDMRs, since now it's available in a much cheaper cost. Otherwise, earlier days, it was the same thing. Yeah, it was. So you can switch down or switch it on to the TSDMRs if the disease is active. So only best thing is to wean it off, or if the patient is not responding, there's no point in anyway continuing. I think in one of the Professor Jha's slide, he showed very clearly how much gap you have to give before discontinuing biologic DMRs to the tofacitinib. Give that gap and then switch it over to the TSDMRs. That's the next options you have.
And with the surgery coming in to picture, sorry to interrupt, Dr. Jha also showed us the recommendation from FDA for us to look at, because we doing any surgical interference, it could be joint replacements, or it could be an osteotomy, or any other kind of things coming in, we have the recommendations. Two, in an emergency situation, how do we tackle that? It could be of joint related, or it could be some other issue of the musculoskeletal issues. How do we tackle that? It could be like a second emergency of a fracture. There's a patient who is on JAK inhibitor, the small molecules, and then here with an emergency, how do we do it? We need to have 3 to 4 weeks window period for a replacement planned surgery. But here, how do we tackle it? Dr. Jha?
Yes, emergency has to be tackled. Not that we will be waiting for the window period to be to arrive and then operate. And it has been found that knowingly or unknowingly, if it was not withdrawn, there has not been very marked difference in wound healing. So it is said that it should be started only after that window period. But there are very many instances when it does not do much harm.
Now, actually, just to add to that, see, there is little few confusion when it comes to these immunomodulators.
Right.
Actually, I would prefer to call these drugs when you use in rheumatoid arthritis as immunomodulator rather than call it as immunosuppressants. In a true sense, they really don't bring the immune system suppression to the extent that what you expect in a normal individuals. So just to make others to understand, actually, I normally tell them with an example of the anti-diabetic drugs. See, in a diabetic drugs, though there are hypoglycemic drugs, but in a diabetic drug, in a diabetic patients, what it does is it normalizes the sugar. Okay, only when you give it in excess more than what the patient can otherwise work, then it goes to hypoglycemia. But otherwise, it normalizes the sugar. I mean, that's what the immune modulator drugs in most of the autoimmune disease. It normalizes the immune system, which is otherwise hyperactive and creating a mess around. So that's why the immunosuppression that what we anticipate when we use these drugs in autoimmune rheumatic disease is not as bad as what I see or what we see when we use the same drug in transplant patients. See, in transplant patients, the transplant patients, most of them are otherwise have a normal immune system or a near normal immune system. The dip is high. Whereas in these individuals, the dip is not that high. So usually you might have seen quite a good number of rheumatoid patients not having much infections as you see in any transplant patients. Rather, in one of the study which we have done long back when I was in Rama, 25 years, when we observed, when I put methotrexate and even the azathioprine, which was available at that time, even the leflunomides, the number of infections significantly dropped in the patients of rheumatoid prior to the treatment compared to the after treatment. This change of shift was because immune system got more stabilized. I mean, those times we used to use a word called immune diversion. The immune system is so busy in killing you, it was not having enough time to protect you from the infection. So that's where it is. So when you block it, rather your number of infection episodes comes down. So as Professor Jha said clearly, tackle the emergency, forget it. So keep in mind that patient was on immunosuppression. So be a little more careful with sepsis and other ongoing infections. Maybe you can use a little higher antibiotic rather than what you would have otherwise used, a lesser antibiotic. Use lytics, bacteriolytic than bacteriostatic drugs. Probably those are the simple things which you use in immunosuppression patients is something which you have to take care actually.
And the patient nowadays
normalizes the immunity when you are taking all these medicines. Okay, then how do you explain the increased rate of herpes zoster in these cases?
Unless... No. See, the immune suppression is there. I'm not saying that. See, what we are saying is you compare the immunosuppression, what I expect if I give the same thing to a normal individual versus an individual with rheumatoid. If I give the same baricitinib or tofacitinib for an individual who is otherwise normal, who doesn't have any hyperimmune responses, his chances of infections are much higher compared to the patient who have an autoimmune rheumatic disease.
Okay, yes.
That's where it is.
Yes, right.
So
this herpes zoster also is not as a rule it comes out. It is only in few patients which has been said to be almost comparable to patients put on placebo.
Placebos. It's not really a big number. Actually. It's not a very big number.
Yes. I think Amarnath.
Can I have one
Yeah, no,
question?
Amarnath first.
Okay, Amarnath.
Okay, sorry. Thank you, moderator Shiva. Now, patients, especially with the geriatric patients coming in, we have a lot of patients on the teriparatide, or probably even on the later ones like denosumab and things like that. How do we go about with the concomitant treatment of these in case if we were to initiate with this small molecules?
I don't think they are contraindications.
Okay.
They can go hand in hand.
Okay.
Continue using denosumab or teriparatide as you have been.
Okay.
Yes.
Yeah, I fully agree with that. That's
right.
Sure.
Yes. Dr. Jha, you had a question to Chandrasekhar. Yes, please.
No, I was first of all trying to recollect. The last EULAR was organized in Denmark, and there a paper was presented that has these small molecules stood the test of time. And then he presented a scenario of complications that have taken place. I stood up and I said that most of your complications are related with the dose 10 milligram twice daily than with 5 milligram twice daily. Number one. Number two, I said, even in my practice, if my patients are more than 60, 65 years older, I do not use 5 milligram BD, I will use only 5 milligram. In some patients, it is said that initially you might use 5 milligram BD, and when the effect arrives, do it half. So the complications are dose related. This is what I wanted to say. And number one, with a personal emphasis, I can say that the European persons or the Western world, the body weight is on the higher side compared to our Asian population. And there was a publication in Japanese regarding a Japanese population that even half the dose, the biologics, they work. And I must say that I have been using a lot of etanercept in my spondyloarthritis patients, and I have used only half the dose. And it gives wonderful results. And they are not biologics, they are biosimilars.
Yeah.
So sometimes in our country where the body weight is less, we can slash down the dose. Your comments, Chandrasekhar, on this?
Yeah, you're 100% correct, sir. Actually, it's actually somehow when they use ulcerative colitis, where they use 10 milligram BD, that's a best effective dose in with reference to ulcerative colitis. That's where all the complication flashed out to say that there were more increased complication, which was never reported when we used 5 milligram twice daily.
Right.
And as you said, what we do also in our practice is we start with 10 milligram if the patient is young. If the patient has crossed 60 or has vulnerability to have thrombosis, vulnerability of a coronary artery disease or anything, we start with 5 milligram. He tolerates it, then we escalate it. And we have some scales which we are developing where we can figure out whether patient has a tendency to have a increased infection, etc. There we will be little scaled down these immune modulatory drugs. And then if he's, as he tolerates, we try to scale it up. I mean, those are the practical ways where we can really work. That's why I mentioned in my the recommendations are only to help you to guide it, and you need to always work in that line to see the best is delivered, actually.
Shiva, do we have time for one more question?
Yeah, please. Yeah.
Thank you. Dr. Jha and Chandru, both of you can answer this and probably give me a little more knowledge on that. Use of most of the patients, whether female or male, or probably my practice also has below 60 and above 60. Now, most of them have IBS kind of a symptom. We may not put them as ulcerative colitis. So what I have done, many a times I've used probiotics in combination with these medications. So is there any experience of that, Dr. Jha and Chandrasekhar?
Well, I will personally say initially when tofacitinib I was not using, had not arrived to that extent that it was cheaper. I even used to get the Bangladesh source because that was again very cheaper. So sulfasalazine was one drug which I was using. But then what I found that in different batches, even by various companies, it was not controlling the symptoms which it should have. So there is some manufacturing defect because I went into the details of manufacturing, and sulfasalazine manufacturing is almost, you can say, a very nasty kind of thing. It colors everything in the lab. So sometimes they keep on making mistakes and they do not provide us the desired result. Now with tofacitinib on, it also helps there. Dr. Chandrasekhar?
Yeah, that's right. Actually, I mean, with reference to the probiotics, we're not really very sure how much it helps when it comes to the inflammatory bowel disease. But when it comes to probably IBS, it may help or may work as a placebo. We really don't know about still about the probiotics. We need to sit and work on that probiotics. There is a lot of work which is going on off late with reference to probiotics, autoimmune disease, gut microbiomes, etc. I think we need to wait for the time to answer, actually. So.
Right.
Yes, Dr. Jha.
Yeah. Since Dr. Chandrasekhar is here, and I said that in the evolution of management of these rheumatic diseases, immunotherapy is likely to become one aspect. How do you rate microimmunotherapy?
I think in the next 10 years, we are going to see a revolutionary change with reference to that, especially CAR T cells and modifying the T cells and dendritic cells, and wherein you can alter or augment the antigen presentation. Thereby, you can even alter the autoantibody profiles. Right. And if you change the autoantibody profiles, despite autoantibody being there, you may not get the disease being on. And there are few studies which are going on, especially with reference to lupus, because we are more focusing on these areas with reference to lupus, because that's one of the disease where we still find very defeating, because at least in rheumatoid, we have come to a point where I can say that I can give you some remission at least in 50–60% of patients. In SLE, we still really fight with few of the difficult cases. There they are trying to use these kind of manipulation of immune system. There is one recent very nice study where they are using anti-dsDNA of IgM type, isotype. If you infuse them, literally the SLE comes down in 1 or 2 stray studies they have done. So, I mean, these are the things which we are looking forward. But the only problem with that is the expense, which is going to be tagged along with it, because it has to be highly individualized. What is useful for me may not be useful for Dr. Amarnath. So that being the case, because of the immune constitutions being changed, it has to be highly individualized. When that comes, the cost is going to be phenomenally high. So I'm not really sure how this all can be tackled. Actually.
Yes, Amarnath.
Dr. Jha, you mentioned in your slide, I mean, as a passing osteoarthritis being inflammatory, we all accept it now, and it's been documented and then well accepted all over the world. Now, with the small molecules also having the effect, are we justified, or how can we, or what is the kind of indication for osteoarthritis? Where is the cutoff point, or how do we go from here if I were to use it?
Right. There is a paradoxical situation, I must tell you. There was an editorial in one of the international journals that since the pathways or the pathogenesis of osteoarthritis and rheumatoid arthritis, they are almost parallel. Till the time that something evolves for osteoarthritis, why not use all the drugs that we are using for rheumatoid arthritis. And lo and behold, even systemic and intra-articular injections were given of TNF alpha and all the other, and they were found not to be effective. They were not effective in osteoarthritis. But these small molecules have become effective because the subchondral bone, it has been able to regenerate. So that is why the small molecule intra-articular becomes so very important. Your comments on osteoarthritis.
Only just to add that, sir, actually, see, the problem in osteoarthritis research, which has been really in trouble, is because of the heterogeneity of osteoarthritis. I think osteoarthritis literally need to be subgrouped as truly degenerative,
Oh yes,
based,
the phenotyping.
Without immunophenotyping, most of these research were done previously to say that it failed.
Right.
So basically, if that's sorted out clearly, I mean, still that classification is under limbo. I think once that comes into a right place, probably the work will be much more better. And that's where the right answer may come.
The loresibhivint that I talked about, intra-articular, will prove to be an ideal, but unfortunately there are cardiovascular side effects for which it has not got FDA approval still.
I think
One last question.
Yes,
only one thing. I made a statement that if it is class 2 or class 3 heart failure, do not use TNF alpha, use tofacitinib. But at the same time, I am conscious that if it is coronary artery disease, use TNF alpha and not tofacitinib.
Not the tofacitinib.
Will you elaborate a bit?
Yes, sir. Actually, see, the use of tofacitinib in a patient with a coronary artery disease or ischemic heart diseases increased incidence of ischemic associated cardiac diseases. So the chance of him having second myocardial infarct or second thrombosis becomes higher. Whereas tofacitinib in a person with a cardiac disease, other than because of ischemic heart disease, if it develops an heart failure of class 2 and above, there using anti-TNF is going to worsen the heart failure. Whereas anti-TNF has a protective against coronary artery disease of atherosclerotic origin. But if the patient has a heart failure, it is going to worsen the heart failure. So if patient coronary artery disease with a worsened heart failure, you have no option of either using tofacitinib or the anti-TNF. The only choice left to you is methotrexate. If patient has coronary artery disease, but has no heart failure, the best is to use anti-TNF. Patient who has the heart failure, no coronary artery disease, you can use tofacitinib. I hope it's clear with that.
Yes, very clear. And only one thing more, that do you feel that use of simultaneous aspirin with JAK inhibitors will lessen the complications?
No. The pathogenic mechanisms, the pathogenic process of JAK inhibitor and ecospirin protections are totally different. That combination helps only in COX-2 selective NSAIDs, because the mechanisms which is not covered by COX-2 is covered by aspirin. Whereas the JAK inhibitors prothrombotic process is entirely different. So aspirin is not going to prevent that process.
So can we conclude this way, that tofacitinib should, or for that matter, any JAK inhibitor should not be the first drug in management of rheumatic diseases?
Yes. Currently, as it stands now, yes.
Okay. I think we are already overshot by 35 minutes. Anyway, the discussion was lively and even it was interesting. That's why I didn't interrupt between the questions being asked amongst the moderators and the speaker itself. Thank you, Dr. Jha, for that wonderful talk on small molecules in orthopedics really it's a game changer. Yes, as you rightly said, it's not the first drug for the rheumatoid arthritis. We should try everything else. Then we have something new if that other medicines doesn't work. I must thank my classmate, Dr. Chandrashekhar, who is an expert rheumatologist and immunologist in Bangalore, for his additional points which added more value to the talk which was given by Dr. Jha. And we are all definitely benefited by your presence, Dr. Chandrashekhar.
Thank you.
I must thank Dr. Amarnath, who has a very great interest, like Dr. Jha, in rheumatoid diseases and spondyloarthropathy diseases, because I know the way they all conducted when I was the president of Indian Orthopaedic Association, the rheumatology sessions. I know them that they enjoy this talk much more than any other orthopedic talk. So that was the reason
No,
why
I'm performing joint replacement also.
we Shiva, to add that we are orthopedicians first and also orthopedic surgeons.
yes, I know, but your interest in this subject is more. I know.
Yes,
Yes.
no doubt.
Yes, definitely. Thank you very much. I must thank the OrthoTV. Dr. Ashok, Shyam is still with us, and all the other people like Dr. Neeraj, Bijlani, and Shyam for this wonderful platform they have provided us. Thank you very much. Thank you all the viewers, and definitely we'll be back with one more talk in the coming new year. Thank you very much.
Ashok, thanks again on my behalf, because you initiated everything and it is done today. Thank you. Thank you very much. Thank you, Dr. Chandrasekhar.
Thank you, sir.
Thank you.
Well,
Thank you. Happy
whenever
New Year
in
to all.
Bangalore,
in
I would like
advance.
to come to your center.
Sure, sir. Most welcome.
OrthoTV, will you please stop the transmission? Rishi?
Dr. Jha is the host now.
Am I?
Yeah.
I am not the host. I cannot stop.
Dr. Jha has been made the host.
But we can leave, na?
Yeah.
Yeah,
I
okay,
think
okay,
we can
great.
leave. We can
Yes,
just
yeah,
can
sure.
leave.
Yeah.
Thank you. Thank you, Chandra.
Thank you.
Thank you,
Thank
Shiva,
you.
Dr.
Bye,
Jha.
good night.
Bye,
Yes.
good night.
Thank you.
Good
Bye,
night.
bye, bye.